Good afternoon, everyone. Welcome to Cancer Reach. Cancer Reach is initiated by Dr. Krishnamani to spread awareness about the cancer and help the caregivers and patient to access the right treatment on right time. We are honored to have you, Dr. Krishnamani, an esteemed expert in the field of oncology with more than 10 years of experience in treating different types of cancer. Dr. Krishnamani is associated with American Oncology Institute of Hyderabad. As you all know, October is a National Breast Cancer Awareness Month, and breast cancer is a cancer that affects countless lives around the world. Last week, Dr. Krishnamani has enlightened us with basics of breast cancer, including the risk factors, types of breast cancer, and lifestyle modification, etc. Today, through this session, Dr. Krishnamani will share valuable insights about the prognosis and treatment options available for breast cancer and the latest advancement in the respective field. Without any further delay, let's extend our warm welcome to Dr. Krishnamani. Doctor, requesting you to give some opening insights to this session, Doctor.
Thank you so much. Thanks for the invitation. As you already said, we welcome everyone to Cancer Reach, which is an initiative to spread awareness about cancer. This is our second session on breast cancer. In the first session, we covered basics like how the cancer spreads, what is breast cancer, how do we diagnose, what are the tests to stage the disease, etc. And here we would come to the important aspects of the types of breast cancer, treatments of breast cancer, role of surgery, radiation, chemotherapy, and overall, how is the prognosis of breast cancer. What I would like to start off is with breast cancer is extremely common. Earlier, it used to be seen in more commonly in the urban women rather than the rural women. Now that is not the case. At the same time, we see a lot of breast cancer in younger women too. So age alone is not a factor. And breast cancer is preventable. Breast cancer is rather screening is available for breast cancer. Breast cancer is treatable, and breast cancer is curable. So these would be my opening remarks, and then I'll be happy to answer your questions.
Thank you, Doctor. That was really a valuable start kick up for the session. We encourage an active participation from our audience. So kindly ask your question in the chat box available in front of the box for you engage in this vital conversation. So let's begin this enlightening live session of breast cancer awareness. I can say it's a part 2. So Doctor, just to start with, what are the available treatment options in breast cancer?
So breast cancer treatment options are like, in general, when you talk about cancer options, you talk about surgery, you talk about radiation, and you talk about systemic treatment. So systemic treatment means any treatment which works all over the body. So that is given by a medical oncologist like me. So you have surgery, which is done by the surgeon. You have radiation, which is done by the radiation oncologist, and you have systemic treatment, which is done by a medical oncologist. Broadly, systemic treatment can be either chemotherapy, which is medicine which kills or controls the cancer cells. In breast cancer, we use something called endocrine or hormonal therapy for hormone positive cancers. We have something called targeted therapy for HER2 positive cancers. We have immunotherapy in some forms of breast cancer, and then other oral medications, which are newer medications like CDK4 inhibitors, cyclin-dependent kinase inhibitors, which we again use in stage 4 hormone-positive breast cancers. So surgery, radiation, earlier it only used to be chemotherapy. Now we have chemotherapy, we have endocrine therapy, we have targeted therapy, we have immunotherapy, we have CDK4 inhibitors. So the landscape for treatment has evolved.
Thank you, Doctor. Doctor, how many types of surgical treatments are there in the breast cancer treatment?
So what we should understand is we are talking about surgery to the breast here. Okay. So when we talk about surgery to the breast, surgery is usually done in breast cancer to cure the patient. When your cancer spreads to other organs like liver, lung, brain, or bone, surgery to the breast is usually not done. So we will confine, when we say we are talking about surgery to the breast, we mean we are doing surgery in these patients whose disease has not spread to major organs. Surgery can be removal of the complete breast or removal of only the tumor. So removal of the complete breast is called mastectomy. Removal of the tumor and leaving behind the normal breast is called breast conservation surgery. Breast conservation itself means you are conserving the breast, but you are removing the tumor. When you remove the tumor, you will remove some normal area around the tumor, which is called margin. So when you remove the tumor, no surgeon is going to cut it into half or leave something behind. So breast conservation means, or lumpectomy. Lumpectomy is removal of the lump, means you are removing the tumor with normal area around the tumor, and remaining breast will be left behind. So these are the two types of surgery. What surgery you are going to do in an individual patient depends on multiple factors. Many years ago, when the science had not evolved that much, breast removal was commonly done. Then we have realized, even if you save the breast, the results are equivalent to removal. So many women come to us in the clinic and say, if it is a small tumor which can be removed, and when we suggest it to them, they say, no, you remove the entire breast. If you leave behind, something will come back again. No, please understand, today results of complete removal are equivalent to breast conservation surgery if you give radiation after the breast conservation. So gone are the days when we were worried that breast conservation is inferior. Breast conservation surgery, and after the surgery, if you should give radiation to the breast, which I will come to later, the results are equivalent to removal of the breast. Now, it depends on the patient, the physician, and certain factors. So if the patient is willing, you should do that. Suppose, imagine the patient has a breast and a small tumor. You can safely remove the tumor, but the patient says, no, I am not for breast conservation. I want to remove the entire breast. You have to agree to what the patient says. So patient's choice. Next is the surgeon's opinion. If it is a small breast and a big tumor, even if the patient wants to save the breast, it may not be possible. The surgeon will say, I cannot remove it completely. So that is a medical reason. So the surgeon will say, I'm sorry, we cannot do breast conservation in a small breast with a big tumor. Other reasons for not doing a breast conservation surgery are, suppose in the breast you have in multiple areas you have the tumor, or you have multiple microcalcifications, or if this patient has received radiation before, the patient cannot receive radiation after BCS. So these are some reasons you will not opt for breast conservation. So put it very simply, surgery for breast is done only when it has not spread to other organs. Generally, you talk about either removal of the breast or breast conservation. It depends on the patient's choice, whether it is possible to remove it completely. And remember, all patients for whom you do a BCS or breast conservation need radiation after that. So suppose you want to avoid radiation later, or if the patient has received radiation before, because of which you cannot give it again, or patient has certain skin diseases because of which radiation is not advisable, then you would tell the patient, because of other reasons, you cannot get radiation. Radiation is a must for breast conservation. So I am not doing breast conservation. I have to remove your entire breast. So these are the broad differences and the reasons for doing one versus the other.
That was an valuable insight, doctor. As doctor, you have started about the radiation. Can we know what is the radiation therapy and how many types are there in the radiation therapy, and like how to select the right one? Can you just give us some?
So what we have to understand is surgery and radiation are methods for local control. So for the disease not to come back in the local area, you are doing these two things. Radiation is nothing but a source of energy directed at that particular tumor site so that the disease doesn't come back. So radiation is of whole breast radiation or partial breast radiation, number one, or it could be a conventional radiation or a shorter radiation, which is called hypofractionated radiation. The conventional radiation is usually for 5.5 weeks, and shorter hypofractionation is maybe for 3 weeks, where more dose is given every day, equivalent to the same dose at the end of the treatment. And these are broadly the different types. of radiation. I am not a radiation oncologist. I am not an expert in the field, obviously, but these are broadly the types. And the technology wise, you would talk about something like 3D CRT versus IMRT. IMRT is technically superior, where you would be giving precise radiation to the tumor, minimizing the effect on other normal area. So when the radiation exposure to normal area is minimized, the side effects are minimized. Side effects on organs like the heart, if it is a left breast tumor, or on the skin or on the lung, are all minimized. But broadly, two things which we should understand: radiation is for local control. All patients who undergo breast conservation need radiation. If the tumor is more than 5 centimeters, we usually advise radiation. If the tumor has spread to the lymph nodes, we advise radiation. So who needs radiation is very clear. If you are dizzy, if you have had BCS, breast conservation, if your disease is usually more than 5 centimeters, which is called T3, and if your disease has spread to the neighboring armpit lymph nodes, in these three conditions, you would give radiation to prevent the disease in the local area. There is another type of radiation called palliative radiation, which is radiation not for cure, but to control symptoms or control pain, which is given usually in the brain if your disease has spread to the brain, or the bones if it has spread to the bones, to reduce pain, to prevent fractures, and to control the disease which has spread to the brain, because no other medicines go into the brain. So broadly, it's either curative radiation or palliative radiation, and we have discussed all the different technical modalities and the fractionation, that is how many days it would usually take.
Jivita, my apologies, you are on mute.
I'm really sorry. Actually, there is a question from the audience came by person called Abbas. After breast removal, can she or can become pregnant, or she can conceive?
So breast removal has nothing to do with the pregnancy or the ability to conceive. So that is not an issue.
Okay. Thank you, doctor. Proceeding ahead with the second question is, what is chemotherapy and how it will work, doctor?
So chemotherapy, as we just discussed, is a medicine which kills cancer or controls cancer. Chemotherapy is given either by the oral route or commonly by the intravenous or route in the saline, through a saline bottle intravenously. So the aim of chemotherapy is either cure or palliation. So if your disease has not spread to other organs, you are aiming for cure. So you will be giving chemo in multiple scenarios. So if it is maybe stage 1 or stage 2 and you have removed the tumor completely, you will be giving chemo for the disease not to come back. That is to prevent recurrence. Sometimes the tumor may be big. The surgeon may say, I cannot operate right now. So you will shrink the tumor. That is called neoadjuvant chemo. So in that setting, chemo is given to shrink the tumor, to make an inoperable disease operable. Surgeon says, I cannot operate. So you shrink the tumor so that it becomes operable. Or it is big. Surgeon says, I have to do mastectomy, but patient wants breast conservation. So you try to shrink the tumor to convert a mastectomy to a breast conservation. So chemotherapy is two types. First, are you using it to cure the patient, or are you using for stage 4 patients, which is palliation? In cure, again, are you giving before surgery neoadjuvant or after surgery adjuvant? Neoadjuvant, why are you giving? Are you making because it is inoperable, you are trying to operate it by shrinking it, or in a patient who needs a mastectomy, you are shrinking it so that you can save the breast. Adjuvant is chemo given after surgery. There is no visible disease. You have removed everything on surgery, but to prevent the disease from coming back because of certain high risk features, big size of the tumor, or spread to lymph nodes, or triple negative variety, or HER2 positive breast cancer, in all these types, the chance of relapse is high. So after surgery, though there is no visible disease, you give chemo so that the disease doesn't come back. Next is what you call is palliative chemotherapy. In stage 4 cancers, you give chemo so that the disease shrinks, the spread to other organs is minimized, and by doing this, you are prolonging the life of the patient and also giving quality of life.
Thank you, doctor. Doctor, there is some questions from the audience. If someone has family history of breast cancer, do they need regular screening results like mammography and MRS?
We discussed that in the last episode, I think. So family history of breast cancer is for people who carry the BRCA1 and BRCA2 gene. People who carry the gene BRCA1 and 2 are advised a regular annual MRI with an annual mammogram. So that is a must. Or after a particular age, they are either advised removal of both the breasts, prophylactic mastectomy, and prophylactic oophorectomy, that is removal of both the ovaries. That is after they have completed their families, maybe after the ages of 35 or 40. But if they do not want to remove their breasts, they are advised annual mammogram with annual MRI.
Doctor, there is one more question from the audience. In early breast cancer, do we need chemo?
So it all depends on what hormone status you have. So early breast cancer means tumor which is less than 5 centimeters and which has not spread to the lymph nodes, number one. So you have removed the tumor. So why are you giving chemo? So that the disease doesn't come back. So if my risk of disease coming back is very low, you will not give chemo. So who are patients who have low risk disease? Hormone positive, HER2 negative people. So somebody who is hormone positive means there is a signal, hormone signal coming, and you can block it with hormone medication. Hormone positive, HER2 negative means signal is coming from above, hormone signal, you can block it. It's a good variety of breast cancer. So if you have a small tumor, if it has not spread to the lymph nodes, if it is strong hormone positive, HER2 negative, if you are a very elderly person, if you have multiple problems like maybe heart issues, etc., then you will say you have a good disease, chances of coming back are very less, it is hormone positive, you are elderly, you may not tolerate chemotherapy, let us avoid. Also, there are certain tests which are being done now on early breast cancer. This is called gene recurrence score tests. So on the tumor after surgery, we send it to the lab. They say, they do some genetic tests or gene recurrence tests, and they say, are you high risk or low risk? So if there is a young person having early breast cancer, you are doubtful whether to give chemo or not. 20 years back, all of them used to get chemo. Now you are doubtful because you may be low risk. So what will you do? You will send the tumor to the lab, do gene recurrence test, that is called oncotype or mama print. In India also there are certain tests like can assist breast, etc. If you come as high risk, then what we will tell you is, see, there's a high risk of recurrence. So take chemotherapy called adjuvant chemo, which we just discussed. If you are low risk, we will say the risk is very low. You don't need chemotherapy, take hormone therapy. Now, but if you're early breast cancer but triple negative, if you're early breast cancer HER2 positive, then you will need chemotherapy. So early breast cancer, hormone positive, good risk or low risk, you don't need, but triple negative or HER2 positive, you will need. Again, if you're unfit for chemo, you will not need, or if you have multiple comorbidities, you may not be given chemo because you will not tolerate.
So there is one more question from the audience. What are some alternative treatments for breast cancer that didn't involve chemotherapy or radiation? What can be done at home to help managing the conditions?
We discussed. So for chemo, apart from chemotherapy, we have hormonal therapy for hormone positive. For stage 4 hormone positive HER2 negative breast cancer, we have oral tablets called CDK4 inhibitors. So these are all tablets. They can be given at home, and you will be on regular follow-up with your doctor if you are having stage 4 disease, and they will do regular scans. If your medicine is working well, your scans report will be good, you will be doing well. These medicines can be continued till you are doing well. So these medicines are not chemo, they are hormonal medications or other oral medications in a specific type called hormone positive HER2 negative stage 4 breast cancer.
Okay, doctor, coming back to our original question and answer session, doctor. So the next question, which is related to the chemotherapy treatment, what are the common side effects of chemotherapy, doctor?
So divide it very simply into 2-3 types. When you give chemotherapy, what problems will you have? When you go home within 1 week or 2 weeks, what problems will you have? And what are the long-term side effects? So during chemotherapy, like any other medicine, you can have some fever, you can have chills, you can have breathing difficulty, you can have vomiting. Okay, these are all called reactions. Or very rarely, you can have chest congestion. People very rarely, very rarely, death also. That's why chemos are given in the hospital setting under supervision. So after you go home, what are the side effects you can have? Early side effects is nausea, vomiting, loss of taste, weakness, etc., diarrhea. Few days later, what you can have is hair fall, or your palms becoming dark in color, or your nails becoming dark in color, fall in hemoglobin, fall in WBC count, fall in platelet counts, fever, infections. Many years later, sometimes chemos can affect heart, chemos can affect the lung, chemos can lead to infertility in young men and women, or very rarely, there can be second cancers like blood cancers, etc. But more commonly, if you have to just summarize, nausea, vomiting, hair fall, loss of appetite, loss of taste, okay, and fall in counts. All these are reversible. They are all simple side effects. If you take good medications prescribed by your doctor, you can withstand most of these side effects. We give usually patients gargles so that they don't develop mouth ulcers. We give them vomiting pills for 3 to 5 days after the chemo. We give them growth injections, so that we call that booster injections or granulocyte injections, so that they don't have infections 24 hours or 48 hours after chemo. So more or less, most of the side effects are, all the side effects are reversible, most of them, and they can be tackled.
That was quite a valuable insight, doctors. Doctor, there is one more question from the audience which has been asked by Naveen Chari. What are the chances that the breast cancer will return?
So see, it is like telling me or anybody that I won't get cancer. Okay, so anybody can get cancer, number one, and once you have cancer, you have a chance of getting a cancer again. So that is why precisely a patient, even after treatment, is kept on follow-up. Now imagine if somebody comes to me today, their surgery is over, radiation is over, chemo is over, and they say, sir, am I cured? I will not use the word cure. What I will tell you is, see, today your treatment is over, you are in remission. That is, there is no disease. You are doing well. Come for follow-up regularly. So the follow-up is every 3 months for the first 2 years. After 2 years, follow-up is every 6 months. And after 5 years, we still ask the patient to come once a year. Usually, after 5 years, we say a patient is cured. But very rarely, 1 out of many lakhs of patients may probably develop cancer after 10 years, 15 years. You never know. So the day your treatment is over, you are in remission, not cured. You are cured only after 5 years, technically. You are under regular follow-up every 3 to 6 months. And for breast cancer patients, during follow-up, we do regular breast examination when they come. We look at the breast, the surgical site, the armpits, the lymph nodes, and the abdomen, chest we examine. PET CTs are not advised during regular follow-up. You only do them if you suspect that the disease is coming back. Otherwise, they are not regularly required. A yearly mammogram is definitely required for all these patients, for the breast which is left behind, for the unaffected breast, or if they undergo only lumpectomy, for both the breasts. So regular checkup every 3 months, they only undergo physical examination, and a mammogram once a year. Scans are done only if there is a suspicion of recurrence, otherwise they are not done.
Thank you, doctor, for the valuable insight. Doctor, there is one more question from the audience, which is from Sumashri, 1997. Can breastfeed mothers have breast cancer?
Yes. So this again we discussed the last time around. What happens is when you are breastfeeding, your breast is for a breastfeeding mother, the breast is dense, and if there is a lump, it is difficult to identify the lump. So please understand, it's a very the number of women who develop breast cancer at that age is less, but be aware. Don't think many a times a lump is mistaken for a milk lump or a galactosele or a lactosele. Don't. If you find an abnormal swelling or you find a lump which is suspicious, even if you are a breastfeeding mother, take medical attention. It may be a benign lump only, but show to a doctor, because your dense breast, and when you're feeding a child, it may masquerade or it may mask a lump which is probably cancerous. Keep it in the back of your mind. Don't panic about it, but go and take medical attention.
Thank you, doctor. There is one more question from the audience. Can men develop breast cancer, and if so, how common it is?
We have again discussed that last time. Male breast cancer is seen. It is seen, I think, in less than 1% of the entire breast cancer population. Men who carry the BRCA2 gene are more susceptible for male breast cancer, and male breast cancer is treated exactly the same way as female breast cancer.
So there is one more question, sir. One of my cousin has a small lump in her breast. Is that a cancer tumor, or please help us here?
Every breast lump is not breast cancer. It could be benign lumps like a fibroadenoma or a fibrocystic disease. Okay, but breast cancer commonly presents as a breast lump. So if you have a new lump, suspicious lump, growing in size, usually breast cancer lumps are not painful. If you have nipple bleeding, nipple destruction, or nipple going inside, inversion of the nipple, or you have suspicious lumps in your armpit, and you have other systemic symptoms like weight loss, loss of appetite, etc., any of these, seek medical attention. So don't worry. What you have to understand is every breast lump is not equal to breast cancer. Most commonly in young people, they could be benign. Even in elderly people, they could be benign lumps. But if it is suspicious, seek medical attention.
Thank you, doctor. Doctor, coming to our original question set, what is our hormonal therapy in the breast cancer? What are the latest treatment options available in breast cancer treatment?
So the hormonal therapy is used in hormone-positive breast cancer, as I told you. These are oral medications or sometimes intramuscular injections. They are not chemotherapy. They don't have side effects like chemotherapy. They are excellent medications and they are very, very helpful. The newer medications are in stage 4 hormone-positive breast cancers, which is called CDK4 inhibitors. They are again very good medications. They are given orally. Side effects are minimal. They are well tolerated and they don't have any side effects like chemotherapy.
Doctor, doctor, there is what is a triple negative breast cancer and how it is treated, doctor?
So we have discussed last time also. We have multiple types: ER positive, HER2 positive, triple negative. Triple negative is ER is negative, PR is negative, HER2 negative. No signal is coming from above, but the cell is growing on its own. So this is an aggressive type. You don't have an enemy coming from outside. You have an enemy in your own house. So this is triple negative. It is aggressive disease generally and has a high chance of coming back. And hormone and targeted therapy are not useful here. We use only chemotherapy. So if you have early breast cancer, you will need chemotherapy to prevent disease coming back. And if you have stage 4 breast cancer, you are given chemotherapy to prolong the life. Also, of late, immunotherapy is being used more commonly in triple negative tests on the tumor called PDL1, etc., which helps us to give immunotherapy for these patients.
Doctor, there is one question from the audience. I am on tamoxifen for last 10 years. Can I stop my medication?
So tamoxifen, if you are taking for 10 years, I believe you had early breast cancer or breast cancer which had spread to lymph nodes and your surgery was done. So generally earlier, tamoxifen was suggested for 5 to 7 years and then now for 10 years also. If you have taken for 10 years, you can stop it. It is safe to stop the drug, and we presume you have hormone positive breast cancer.
That was a valuable insight, doctor. Doctor, coming to the next question, what is HER2 positive breast cancer and how is it treated, doctor?
So this is the other type which we discussed. The HER2 signal is coming from above and you are targeting with HER2 therapy. There are two main medications, trastuzumab, pertuzumab. Another medication is called TDM1. There is a newer medication called TDX1, etc. So basically, HER2 positive means there is a HER2 signal. You are blocking it with targeted therapy, trastuzumab, pertuzumab, TDM1. The trastuzumab is the most common medicine in this. it is given in saline. If it is given with pertuzumab, nowadays you can give it like an insulin injection, also subcutaneous. It has no side effects like chemotherapy, but it is usually combined with chemotherapy. And after chemo is stopped, these medications are continued. In stage 1 and stage 3, stage 1 to 3, these medicines are given for at least 1 year. And in stage 4 breast cancers, they are given till the patient is doing well.
Thank you very much, Doctor. Doctor, there is one more question from the audience which has been asked from Shweta Pani. Is there any advancement in treating metastatic breast cancer?
Yes, so in metastatic breast cancer, you have immunotherapy for triple negative breast cancer. You have CDK4 inhibitors, palbociclib, ribociclib for hormone positive breast cancer. For HER2 positive, we have medications like trastuzumab, pertuzumab, PDM1. So what is happening is we are moving away from chemotherapy and going to these medications, definitely in stage 4 breast cancer and also in earlier stage. So there has been a lot of advancement in technology, in scanning, advancement in medications, like as I told you, gene recurrence score, which we discussed, which is an advancement to find who needs chemotherapy, who doesn't need chemotherapy.
Thank you, Doctor. Doctor, there is one more question from the audience. How to find if I am having breast cancer?
Do regular self-breast examination. You have any suspicious lump, show your doctor. If your doctor feels there is nothing in that, it's a benign lump, leave it alone. If you're above 45 years, get an annual mammogram done.
Doctor, coming back to the question, what is immunotherapy in breast cancer?
So we just discussed it some time back. Immunotherapy is a new treatment in cancer. Medicines which boost your immunity to kill cancer. They don't have side effects like regular chemotherapy. It is still an evolving part of breast cancer treatment, used commonly in triple negative breast cancer. So it has its own set of side effects. It boosts your immunity and can sometimes damage your thyroid gland. You can have hypothyroidism. You can have skin problems like dermatitis. You can have diarrhea, etc. But chemotherapy side effects like hair fall, nausea, vomiting generally are not there. And immunotherapy is common in other cancers that we are using in maybe in lung cancer and kidney cancer, but in breast cancer, we are commonly using it in triple negative breast cancer in stage 4 setting.
Was an excellent point, Doctor. Doctor, what is the prognosis of a breast cancer patient?
So by the end of the session, I want people to understand, our listeners to understand that breast cancer is curable. The prognosis is excellent. You talk about stage 1, stage 2 breast cancers, which is more than 90-95%. Stage 3 breast cancers is more than 70%. Even stage 4 breast cancer, if somebody is hormone positive, HER2 negative, the average survivals are more than 5 years now. For HER2 positive breast cancer, the survivals are more than 2 to 4 years. It's only the triple negative cancer which is aggressive, but we are getting around that too. So it is not a deadly disease what it used to be, and the prognosis is excellent. It is definitely curable if detected early, and it can be detected early too.
Thank you, Doctor. That was an excellent point. Doctor, there is one patient, there is one question from the audience. It's something like they are asking that if I have a breast injury, is there chances that I can develop breast cancer?
Unlikely or not likely. No.
So, Doctor, these were some of the important discussion or the questions which were the excellent insights which you have given it to us, Doctor.
Thank you so much, Geeta. Thanks to everyone.
Thank you very much, Doctor, for your valuable insight on different types of treatment and prognosis, Doctor, which you have shared with us. That was an excellent insight. It is told, Doctor, knowledge is power. So with your knowledge and your experience, I hope this communication has enriched the people for more information and to learn, and also to be the part of being informed and spreading awareness, so we can make a significant impact in the fight against the breast cancer, Doctor. So thank you everybody for joining this live session. I hope this session was quite a learning point for all of you. Thank you, Doctor. Thanks a lot, Doctor.
Thank you so much.